of Bioengineering at Rice University. So we're thrilled to have Dr. Fraser here with us today. We also have Dr. John Breinholt, and he's from UT Children's Memorial Hermann. And Dr. Breinholt's clinical interests include non-surgical treatment for congenital heart disease, implantation of closure devices, stents, and transcatheter valves, and applying emerging therapies to very young patients. In practice, since 2008, he treats newborns through adults who suffer from congenital heart disease. Dr. Breinholt currently serves as Chief of Pediatric Cardiology at Children's Memorial Hermann Hospital and is the Director of Division of Pediatric Cardiology in the Department of Pediatrics at the University of Texas Health Science Center at Houston, UT Health Medical School. So we're thrilled to have him here as well. We also have Dr. Tara Karamalou, and she's the Director of Vascular Research Institute at Phoenix Children's Hospital and practices clinically as a congenital heart surgeon. She orchestrates the clinical and translational research activities within the PCH Heart Center and is currently the chair of a regional Southwestern collaborative of 10 hospitals providing pediatric cardiac surgery care in the Southwest region. Her major research interests are concentrated on understanding primary drivers of important national metrics in congenital heart surgery and ongoing quality assessment in the congenital heart surgery population. And finally, on this panel, last but not least, we have Dr. Ming Tse. And Dr. Ming Tse is a pediatric cardiac surgeon who has clinical expertise in the surgical treatment of complex congenital and acquired disease of the heart and great vessels in neonates, children, and adults. He also has experience in hybrid cardiac procedures and neonatal open heart repairs. And Dr. Tse is from Mott's Children's Hospital and has come down all the way from Michigan. So I'm going to welcome Dr. Fraser up, and we'll have the whole panel speak, and then there'll be time for questions and answers.
Is the lapel mic working? Oh, good. All right. Well, good morning. Welcome. Thank you all for being here. Michael Montgomery presented a really inspiring keynote address, and it's an honor and privilege to follow him. I have to say, unfortunately, though, I'm not an Aggie fan. I wish you could take that clip of you tackling Vince Young out of it. Otherwise, it's great. But thank you. Very inspiring, and I know that you're going to do marvelous things for the broad field of congenital heart disease. So welcome to Texas Children's. We're very proud of our hospital. I am the Surgeon-in-Chief here. We're the largest children's hospital in North America, 745 inpatient beds. This morning we have 145 newborns in the hospital. We have 107 children in our pediatric critical care units, including 33 children with congenital heart disease. So I'm told it's not loud. And we have wonderful facilities. We did 30,000 operations here last year. We have 120 full-time specialty surgeons in all aspects of childhood surgery. In this pavilion for women above us, we delivered 6,000 babies last year. The only thing we did wrong in the pavilion for women design is we put a support column right in the middle of our main conference room. We were going to take it down, but the building would fall down. So probably that's not a good idea. I share all of those statistics with you because we are very proud of our hospital. We're very proud of our hospital, but to be clear, we exist only because of you. We have no inherent right to be here on Fannin Street in Houston, Texas, except for the children and the families, the mothers and the babies. And we must always remember our purpose, and that is to take care of you all and to be better and better and better. And so forums like this really help us be better. And I look forward to hearing from our colleagues from across the country. We all learn from each other. Perhaps at certain levels we might be competitors, but we're friendly competitors. And we're all trying to help each other to do a better job for children with congenital heart disease. So my task was to share with you some progress in congenital heart disease, and I'll try and blitz through this. I thought it would be fun for you all to just know a little bit about Houston. Hey, Phil, is there any way this screen could be full here on the thing? So Houston, you've been reading a lot about or hearing a lot about. Because of Harvey, Houston will rebuild and be stronger than ever. It was a bad event for us, but what a great city rally we've had. And the rally from across the world literally has been amazing. They just had an event, as many of you all know, last night in Austin called Texas Strong, focused on Harvey relief. It was a wonderful thing. So we're the fourth largest city in the United States. Big, fast, expansive, growing city, but we're very close to sea level, and that does present some challenges. We were really thrilled to have the Super Bowl here last year. Wonderful cultural and performing arts, a wonderful community of diversity. Last night, my wife and I went to a wonderful Thai restaurant. I felt like I was in Bangkok. We have all sorts of opportunities in Houston, which make it an exciting place to live. Of course, Houston is known for several things. We're known for Houston Mission Control, the Space Center, and that is very, very exciting. If you haven't visited NASA, go. It's well worth your time. Really quite amazing. We're the energy capital of the world. Texas is known for the oil and gas industry, and Houston has been the epicenter of that for a long time. We have wonderful sports teams. We're really thrilled with all of our teams. We're really rooting for those Astros coming into the playoffs, and very exciting time. It's a great place to be, but we're most proud of the Texas Medical Center. The Texas Medical Center is, it almost defies description. It's a city within a city. It's the largest collection of healthcare institutions in the world, and in the foreground of this photograph was a previous iteration of Texas Children's, and you can kind of distinguish the Texas Children's family by the pink granite that is our trademark. The Texas Medical Center is like an anthill of activity. Over 10 million patient encounters last year, 180,000 surgeries across the various hospitals, 2 medical schools. Very, very vibrant place. Those of us at Texas Children's on the full-time faculty are members of the faculty of Baylor College of Medicine. That has been our primary teaching affiliate at Texas Children's for now over 60 years. And the Texas Children's family, we're here on the main campus where we're about to open our new critical care tower. I'll talk to you about that in a minute. Then we have this pavilion for women, designed to focus on complex deliveries, prenatal diagnosis, fetal interventions, and perinatal care. Then we have a West Campus hospital out in Katy. It's about 30 miles from here, and we just opened last April a hospital in the Woodlands about 40 miles to the north to try to provide the most available and comprehensive care for our patients and families. It's part of an integrated delivery system of Texas Children's. We have quite a number of locations across Greater Houston, including primary pediatrics practices, acute care and urgent care centers, and the various hospitals I described to you. So many of you, maybe all of you, have been a part of the evolution of care for congenital heart surgery, congenital heart disease. I've been at this since about 1990, and the field is almost unrecognizable from that point forward. And this is just my sort of personal synopsis of some high water marks that I think have been transformative for our field. And then I'll tell you some things that I think are ongoing and perhaps speculate about what may happen in the future. You could probably poll all the pediatric cardiologists and surgeons in the world, and they would all have their own timeline, and we could all have fun talking about that. But here's how I break it down. 1940s, early palliative surgery, the Blalock shunt, Blalock and Taussig. Early 1950s, early open correction, the use of some form of circulatory support, either controlled cross-circulation using a parent as the pump oxygenator, as Dr. Lillihei did at the University of Minnesota, or the pump oxygenator, mechanical pump oxygenator that Dr. Kirkland and others worked on. We got started here at Texas Children's in 1956. Dr. Cooley and Dr. Dan McNamara, my partner Dan Penny's predecessor, Dr. McNamara and Dr. Cooley, brought pediatric and congenital heart care to Houston, and they were off and running. Then into the 60s, some more complicated operations. The Sinning and Mustard operation for transposition of the great arteries, becoming more and more complicated. Surgery for single ventricle continued to evolve. The Fontan operation, which was brought on in the late 60s, early 70s, a radical step in thinking that you could have essentially a separated circulation without a mechanical power source for the Fontan. Rastelli operation to make a connection between an atretic right ventricular outflow tract and the pulmonary arteries. And then the era of newborn heart surgery, capitalizing on the observation that McNamara and others made that we need to get after critical heart disease earlier and earlier and earlier to give the children the very best chance of a good outcome. The Jatini operation, the arterial switch operation, first done in an infant, and then Aldo Castaneda, the newborn arterial switch operation. And then we really started to step off into things like hypoplastic left heart syndrome, where Bill Norwood very rightly deserves the designation as the patriarch of palliation for hypoplastic left heart syndrome. Right here in our own hospital, Dr. Cooley performed the first successful infant heart transplant in 1984, really emboldening us to go more and more and more into complex things. 1990s, I can absolutely, Dr. Penny and I were fellows together. I can absolutely remember when we heard about Roland Hetzer in Germany, who had developed a small mechanical pump, now known as the Berlin Heart, that was going to revolutionize mechanical circulatory support for children. That in and of itself is an enormous story and a frustrating story. But Dr. Hetzer deserves enormous credit for staying with that. And then as we came into the last part of that last millennium, the idea of a focused children's heart center. Children, patients with congenital heart disease, deserved, mandated a different level of focus and attention. And that's when we got to build the Texas Children's Heart Center that many of you toured earlier. We started moving forward with more forms of mechanical circulatory support, and then also this idea that adults with congenital heart disease also merited focus. I put my face on there not because I was a great innovator, but to point to some of the challenges which we all realize still today in moving forward in the care of children with congenital heart disease. The regulatory process is very slow. So back to the Berlin Heart, created in 1990, 2013 was the first approved device in North America by the Food and Drug Administration. Imagine it took all that time for the same pump to be approved in our country. And then this millennium, I'll talk a minute about public reporting, very, very important step forward. Fetal intervention, small devices, use of stem cells, 3D printing, very exciting time. What is next? The sky's really the limit. So here are some of the things that I think have been game changers in my career. And again, we all could have different thinking about what that list looks like. Focused Children's Heart Center. So children's hospitals have evolved enormously over my lifetime. This is Texas Children's when it opened in 1954. The primary premise, as I alluded to earlier, is we throw our doors open to everyone, irrespective of anything. We're here to take care of and serve the needy. These are some of our forefathers, Cooley, McNamara, and in the middle, Ed Singleton, who was the first chief of radiology here. They were a great partnership. We got into the newborn game very early here. Here's a series of 120 newborns operated on Texas Children's, published in the journal Surgery in 1959, the year after I was born. And then, as I said later, this was really an exciting place to be in the milieu of a giant medical center with places like the Texas Heart Institute that were doing 5,000–6,000 open heart surgeries per year in a single hospital. But what we found, and what was a catalyst for transformation, is when children are embedded in a system that is not childhood-centric, the results are suboptimal. And so these were the results at our own hospital from 1990 to 1995. 100% mortality for the Norwood operation, almost 25% mortality for the arterial switch operation. We had big work to do. And so we focused on the primary premise, get the best people to the bedside of the patient all the time. My mentor, Roger Mee, Dr. Penny's former colleague in Melbourne, Australia, a brilliant, forward-thinking leader in congenital heart surgery, perhaps in some ways largely unrecognized to the degree that he should be. Our current nurse director of our cardiac ICU, Hermann and I started working together at the bedside way back when, focusing on the children. And our team today has blossomed in ways that none of us could have ever possibly envisioned. We're now 5 surgeons, 13 full-time cardiac anesthesiologists, 59 cardiologists, on and on and on. Every member of the team is important. Every single member of the team is important. Again, the notion of an integrated heart center, getting the practitioners to the bedside easily and in a focused fashion, has really, really worked well for us. I would submit it's the optimum environment for children with congenital heart disease. We've continued to grow. Well, of course, the population of Houston has grown, but much of this growth is wrapped up in the success of patients surviving who formerly didn't survive. And that translates into a lot of additional responsibility. Again, we have been big proponents, before there were even such things as risk stratified categories, of how we're performing. And this is just a snapshot of some of the performance at Texas Children's over the last number of years. I won't belabor the different categories. It's a very interesting and importantly evolving subject. Dr. Kermalu is integral to this sort of important evolution, and we perhaps would have time to talk about during the discussion session. But the core message I would hope you all hear is we should be transparent with the public about how we're doing, I believe. We have great leadership in the Heart Center, wonderful faculty. This is our faculty photo just last year. This is what's ahead for us. Opportunities to continue to expand our programs, to continue to evolve in a way to serve you all, your patients, your children, yourselves, your families optimally. So this new critical care tower is a very exciting proposition for us. And in the Heart Center, we'll be on 8 contiguous floors. You see there, we've got the ICUs over 3 floors, dedicated cardiac operating rooms right next to the operating room, cath labs, intraoperative MRI. We've got this all sandwiched between the doctors and all our teams. So trying to make sure that we can be right there when needed. Outcomes and expectations. This has been transformative in my career. So I can absolutely remember as a young resident at Johns Hopkins when I heard that Dr. Norwood was having success with hypoplastic left heart syndrome. And none of us could quite frankly believe it. We couldn't believe it. So fast forward to today. Very high expectations for that condition. Now we're still learning so much about it. But that's been a game changer, changing our expectations, continuing to raise the bar. So the 2 paradigms that I really think are fascinating are the arterial switch operation and the Norwood operation. So again, Aldo Castaneda, Bill Norwood, amazing leaders who said we should reach higher. We should reach higher all the time. Transposition of the great arteries, the arterial switch operation, that now has become something where we have essentially the expectation that every patient is going to survive. Every patient. And we've not had a death in this hospital in this millennium with transposition of the great arteries. That is completely different than when I got started. In fact, the arterial switch operation was sort of experimental when I got started as a young surgeon. Hypoplastic left heart syndrome, we've made enormous progress. We still have ways to go. It's a very challenging proposition, as many of you know. The stages, there are different ways we approach this. This is a classic Norwood type reconstruction where the pulmonary artery and the aorta are amalgamated as one. And in this iteration, or this drawing, a systemic to pulmonary shunt is created. Then the second stage, or bidirectional Glenn, third stage, the Fontan. And now we have lots and lots and lots of patients who've gone through these various stages. And the question then becomes, what happens as life goes on? What happens when they're 40, 50, and 60 years old? We don't know yet. We don't know, and we're going to have to learn. And thusly the need for the congenital, the adult congenital paradigm to continue to respond to this evolution. So again, back to those outcomes, we're proud of our progress. We still have a ways to go. Neurodevelopmental focus. So since we're able to now be very confident that we can get the patients through the operations, as Dr. Penny shared with the group earlier, we very much agree our responsibility is to make sure that children who become adults have the very best quality of life. And that means that they have the very best opportunity for normal brain development. Newborn brains are vulnerable. We all know that. We expend a lot of effort thinking about that. And when I got started, thinking about the brain was just this. It was a black box. We didn't have any real way to monitor the brain, absolutely in the operating room. And it was a great cause of anxiety for any thinking heart surgeon. And we know if we go looking, so if we look at the brains of children with congenital heart disease, they're stressed brains. They're brains that are vulnerable to injury. And so our approach at Texas Children's has been to do everything we can in the continuum of care to optimize brain protection and thereby brain development. I won't go through all the things that we've published about this, but this has been a primary focus of our center for now more than 2 decades. And our core principle in the operating room has been quite simple: deliver oxygen to the brain during the operation. This is a subject of enormous debate in our field, but this has been our primary core premise. We do that by perfusing the brain during complex reconstructions, including those reconstructions that involve a repair of the aortic arch. And we have found that if we weren't looking, we wouldn't know what we weren't finding. So this was just a little vignette that my colleague Aaron Gottlieb published a number of years ago, and it's based on our bicortical oxygen monitoring in the operating room. And we found in this individual that our cannula position for the cardiopulmonary bypass machine wasn't just perfect. So one side of the brain was not getting sufficient oxygen, or we were concerned about that. So we just moved the cannula. We moved the position. In those days, those black box days, how would we possibly have known? We would have no way to know that. Seemed quite logical to us. And now this has evolved further with Dr. Penny coming here, Dr. Shecker-Damian, many other colleagues across Texas Children's. We now have a neurodevelopmental team focused on making sure we're watching the children very closely as they get older. Mechanical circulatory support heart failure in children is a prevalent and growing problem. There is intrinsic heart failure, so patients with structurally normal hearts who then develop pump failure. And then there are the models of heart failure of palliated congenital heart disease that subsequently need something. And this is only going to continue to explode in terms of need. Our former colleague Joe Rosano just looked at admissions for heart failure in the United States over a year, and this is a sobering reality. Patients who are admitted, children who are admitted to the hospital with heart failure have a high risk of dying. We've made progress in being able to support the circulation. We have a long way to go. In that arena of advocacy that Michael Montgomery alluded to earlier, it has to be continually shouted that children are disadvantaged compared to their adult counterparts in device development. The regulatory pathway is challenging, the capital investment is limited, the appetite of industry is limited, and it means that translates into children having to be relegated to a lesser status. And this is, of course, unacceptable. So here's where we are today. We have temporary devices like the Rotofo device that we use for temporary left ventricular assist device, or ECMO. We have an Impella device, which is a catheter-based acute either left ventricle or biventricular option. And then we have adult devices that we put in children. So we have the HeartMate 2, soon the HeartMate 3. We have the Heartware device. We have the Syncardia total artificial pump. These are adult devices. We're able to use them in children with some clever manipulations, but these are adult devices. The only device that is still FDA approved for small children is the Berlin heart. And again, That didn't happen until 2012, 2013 tells the whole story. We know that if we focus on this in children, we can have good results. This is how we think about it at Texas Children's. This is sort of our size algorithm for the different pumps that we would place. Again, the Berlin heart really is the lone survivor right now for small children. But there is some glimmer of hope on the horizon. We're about to start enrolling patients in what's called the Pumpkin trial for kids, pumps for infants and kids. This small device, which is a small continuous flow device, which goes in the bottom or the apex of the left ventricle, designed by Robert Jarvik, is about to start to be implemented in a prospective randomized trial for children with heart failure. On the horizon, total artificial heart. Total artificial heart will be, in my estimation, the solution for the next generation for some patients. And our wonderful place here in the Texas Medical Center gives us some really interesting opportunities. This is Daniel Timms, who's a brilliant innovator in the world of mechanical circulatory support. And what Professor Timms has developed is a magnetically levitated, no moving parts are in contact with each other, impeller designed, 3D printed titanium total artificial heart. And here's how it works. Red blood in and out to the systemic circulation, blue blood in and out to the lungs. And these dual impellers are magnetically levitated, so the heart is capable of responding to the needs, the preload and afterload of the patients. And the results in animals so far are astonishing. And the cool thing about this heart is that the theory is the designer would be able to print a heart specifically designed for the size of the patient. So you can imagine what opportunities that offers for us. Longitudinal thinking and management. So again, going from the surgeon-centric focus of we're going to do this operation, we do it well, out of our hands, to thinking about the whole continuum of the patient's life and how we can optimize that life. So that means integrated multidisciplinary management, just like we have here in this group, who is discussing this challenging problem, and that is sudden cardiac death in athletes. And a very small subset of those patients, as many of you all know, have this condition where one of the coronary arteries in their heart arises abnormally, so-called anomalous aortic origin of coronary arteries. And these are some of the iterations of that, how unbeknownst to the patient or family, there could be a potentially lethal problem. So we focused on that here at Texas Children's in an integrated coronary anomalies program. We're collaborating with our colleagues across the country and across the world to try to understand this optimally. And again, much more we need to learn, but in my mind, emphasizing the need for longitudinal management, integrated team care, and careful analysis of data and outcomes. Then just a little bit about fetal diagnosis and intervention. Again, we believe in this so strongly at Texas Children's that we built a hospital. That's why we built this hospital. Now, it's not unique to the Heart Center. Of course, we have other fetal conditions that we treat in the pavilion for women, like neural tube defects or spina bifida, which we can treat in the womb. Other forms of things like tumors that children develop or airway problems, and then also intervention for congenital heart disease, like this baby who had hypoplastic left heart syndrome with an intact atrial septum, who had a trans-abdominal, transuterine, transfetal intervention to place a stent in the atrial septum. This patient was successfully delivered and has now gone through 2 of 3 stages for hypoplastic left heart syndrome. We know, unfortunately, that in this country, in this state, where you're born has impact on how you do. That certainly shouldn't be in the United States of America, but it's a fact. And if we don't pay attention to that, we're missing opportunities to improve. Dr. Shane Morris showed that very, very well. We're looking very carefully, as our colleagues in Boston and many other places around the world, how are we doing when we learn about the problems, in fetal life, we intervene on them, and then take care of the patients in postnatal life. Things like innovations for the more challenging variations of hypoplastic left heart syndrome, the so-called hybrid operation would be one of them. Again, that's our pavilion for women, where we are right now. Now, what about the future? Just a few closing ideas. Public reporting is here to stay, and many of you, maybe all of you, have experienced this notion. It is a subject of enormous debate. We are not perfect in the arena of public reporting, but I always counsel families. As you might imagine, I have a lot of families who ask me things about either their unborn child or their child that's facing surgery, perhaps their child who's already had surgery. From around the world, I get questions. And most of those children, frankly, don't come here for care, and that's just fine. But I tell the parents, and frankly, I would tell the referring doctors, to be critical shoppers. To be critical shoppers. The decision you make will have lifelong impact, as you well know. So you're empowered. It is your inherent right as a parent or a patient to ask tough questions. And they're not actually that hard. The questions aren't that hard, are they? They're pretty simple. How many do you do? How many did you do last year? How many did you do over the last 5 years? Who's on the team? Who's there, not Monday morning at 10, but who's there Sunday morning at 3 a.m.? Who's there when my primary surgeon is out of town and the child has a cardiac arrest? Who's in the intensive care unit? How are the nurses trained? They're pretty basic questions, and everybody has the right to ask them. So again, this has been part and parcel of our belief system for many, many years. We have outcomes books. Are they perfect? Absolutely not. Now, we are proud of our rankings. We are very proud of our rankings. And again, we don't have time to talk about the star rankings, the star ratings. And methodologies continue to evolve. What I might say to all of you all is there are a lot of great places in the United States where children can have heart surgery. That is a for sure. And just because one center might necessarily be ranked over another is not the singular point of how you should decide about care. But participation, that's a red flag. If someone's not participating in the game and they're not analyzing, that's a red flag. And we are in Texas, so we do have to brag a little bit. So we're happy about this. We're very happy about this ranking. We know it's fragile, but it is gratifying to see a lot of decades of work come to fruition through this work. We'll continue to evolve the value-based paradigm, making sure that what we spend on healthcare translates into the best possible outcomes. We've been a part of this for a lot of years. Part of the business school likes our case and teaches it about every semester of their value-based healthcare course. We'll continue to do that. That translates into integrated care at the bedside. And then it helps us, and I'll end with this slide, it helps us look to the future. So this is all we really care about, right? We care about having patients and families be able to ask these sorts of questions. Now, the reason I'm writing you this letter is I'm asking for the blessing to be able to get on the football team and suit up for my senior season so that I can be Michael Montgomery. That's why we're here. And we want to keep asking those questions and making sure that every child has the opportunity to have that sort of happy life and then beyond, of course. So I'll stop there, and then I think we'll have some time for questions later. Thank you.
Good morning. It's really exciting to be here. I'm originally from Utah, so I have no skin in this game. I have to say, though, that between Dr. Fraser and Mr. Montgomery, I think I know who's going to take who. I think that he could probably take both of us, so I'm just going to watch the sidelines. It's actually it was very interesting to watch the evolution of heart surgery. And I actually trained here, and seeing the Bakey ventricular assist device, 2004. I actually was the cardiology fellow that took care of the first patient that received that. So it's always kind of interesting to see where you place in history. One of the things that I'll also talk about is you'll notice that they began kind of in the 40s, and we really didn't get our start until the 60s. And probably most importantly is, as much as I'm going to talk a lot about avoiding surgery, it's not meant to be seen as that we don't like surgeons or that we're competing with surgeons, because hopefully the message you get is how integral they are. We recently, I'm at University of Texas at Houston, down at Children's Memorial Hermann Hospital, also unique to Texas, that I'm only 2 blocks away. And we recently were looking for a new surgeon, and I had 2 criteria for the surgeon that we found. One was they were excellent, that their outcomes were excellent, but number 2, it was someone I could work with, not just as a cardiologist, but as an interventional cardiologist, and that will become evidence. And so fortunately, this is our new surgeon, Dr. Salazar, somebody who is an international reputation as a collaborator with interventional cardiology, which is very exciting for me. I think the only difference if he were up here is he probably would have put his picture on the other side. So the first innovation in interventional cardiac catheterization, when we were previously just a diagnostic field, was the balloon atrial septostomy. So if there's anyone here that had, or a child that had detransposition to great arteries, this was the first procedure that we were able to do in the cath lab. Previously, this was something that was done, these children were born. A surgeon would go in solely for the purpose of opening up a hole between the 2 upper chambers of the heart. And then they were sent home with the idea they would come back later for surgery. Of course, later, as Dr. Fraser talked about the arterial switch procedure, that made it to where they get surgery a lot sooner. But we still do this procedure today to give them a little bit of time before that surgery takes place. And so basically what it is instead of a surgeon going in and making a hole between the 2 chambers, we introduce a balloon, we inflate the balloon, and then we pull it across. And I still consider this probably the most violent procedure we do. As you can see, pretty much the whole patient gets pulled down by the balloon. Another kind of way in which our field has evolved is aortic valve stenosis, or different diseases of the valve, in which the valve just doesn't open correctly. The valve leaflets are fused together. And again, initially, the way this was treated was a surgeon would go in, they would cut it open, and they would make incisions on the valve. But then surgeons decided that they wanted to be less invasive. And so one of the ways in which they addressed that is they started doing what was called a closed valvotomy. So they would open up the chest, but then they would introduce a dilator to kind of open up the valve. And what we saw with that was, well, we have an opportunity here. How about we avoid the surgery altogether, introduce a balloon across the valve, and see if we can accomplish something there. And so here's an example of a very young child where the valve just isn't opening like it should. So we introduce a wire, and then we follow it with a balloon. You can see that waste in the balloon that resolves. That's kind of opening up those valve leaflets, similar to what a surgeon would do with a dilator. And then this is just the end showing that the valve doesn't leak, it works, and then this child was able to avoid a surgery. This is probably the area that I'm very excited about. Payton ductus arteriosus, not the most severe heart disease, certainly not hypoplastic left heart or many of the other very complex heart diseases we deal with. But I'll tell you why I'm excited about this is because it really demonstrates what we have done over the years with this disease. This is the first device that was ever used to try and close a PDA. It was done in 1967. Dr. Portsman introduced what's called the Ivalon plug. The reason why I bring this up is the introducer size, and I know that using words like 16 to 22 French may not mean much to most people, but to give you a sense of how big that is, that's about as big around as my laser pointer. That's an enormous tube. It's like putting a garden hose in the body, and if it's a small child, you can imagine how challenging that might be. And what I'm going to ultimately show you is that today we can put devices through things smaller than this coffee stir. And so really this demonstrates kind of all the effort and emphasis placed on getting these types of technology to children. So this is the second device that's introduced, the Rashkin umbrella, back in 1979. Again, it didn't work very well, and it used really large catheters. Then came the Sedaris button device. This was actually part of the Dr. Rao, who is my predecessor at Children's Memorial Hermann, was a part of this study. Again, big device, didn't work really well. The patella occluder, 1993. We're getting a little bit too close to where we are today, still didn't work very well. But here's where we actually started to make some ground. These coils have been developed to close off blood vessels, and Dr. Canby thought maybe I can do something with this and introduced the idea of closing PDAs with coils. And this actually we still use today, and it works really well in really small defects. But in larger defects, this was prone to a lot of problems, and there were still a lot of patients that we weren't able to treat. And this just shows you a picture of when a coil is placed in the PDA. The Niticlu device, introduced in 1992, didn't get FDA approval actually until the 2000s. It's a device we use occasionally, but doesn't use a whole lot. And this is a device actually that is of historical significance here. It was in part developed by Dr. Grifka when he was here at Texas Children's Hospital. And it was a device that basically was a bunch of coils introduced into a sac, and it had a little bit of limited applicability and actually is no longer produced. The Amplatzer PDA occluder that is now, I guess, sold by Abbott after it was bought from St. Jude, after it was bought from AGA, is probably the device that revolutionized our ability to treat this disease. And it's a wonderful device. It collapses into very small catheters, 5 to 7 French, which is probably about the size of a regular straw. We're able to treat a lot of these devices, a lot of these defects in children. And I want to distinguish children from like infants or babies. So we're getting these kids when they're several months old, up to where I think the largest person I've closed a PDA was a 26-year-old. But where we really were missing were the tiny, tiny babies, the babies that were premature, the babies that weighed 1 or 2 pounds. We don't have anything for them, at least up to this point. But then Amplatzer developed a device called the vascular plug. Again, just like Dr. Fraser says, we suffer the same problem. Most of the things that we use are not designed for the things we use them for. They weren't designed for our patients. But the vascular plug offered an opportunity to maybe get something inside the PDA and not be poking out in what's otherwise very small structures, because what we see in these tiny kids is the PDA is actually as big as the aorta or the pulmonary arteries, the very blood vessels that we want to keep around. And so this device offered us some promise, and some of my videos don't really work, but this kind of just gives you a sense of that. This is the PDA. That's the descending aorta. It almost looks like it's about the same size, and that's what we encounter in these really tiny babies. And so this was the first device I think we really started using for this purpose, and this just shows the delivery one. This is the only video of this particular one I was able to get to work. But that's okay, because I'm even more excited about what I'm going to show you next. This is a device that is developed by Medtronic called the microvascular plug. This is the one that actually goes through something smaller than the coffee stirrer. This device was designed for interventional radiologists. So when someone has an aneurysm or some type of vascular abnormality in their brain, this device was designed so it could kind of wind its way up and get up into the brain. It worked out really well for us because our babies are super tiny and fragile, and you cross valves and they get really unhappy and they tell us very quickly in the cath lab. But this allowed us to get something really small, very non-intrusively into those places. And so it's just another picture. And so here's an example of one of the procedures that we do. And there's the PDA there by echocardiogram, and you'll see a lot more echocardiograms than an interventional cardiologist will typically show, because we limit what we do with the cath lab tools. But here it is taking a picture of it, where we have a very tiny catheter. It's a very small catheter taking this picture, and then we're able to deliver the device. And you have to look pretty close to see the device. You might see a little tiny pin right over here. This device is almost invisible, but this picture is primarily taken to make sure it's where I think I put it. And then before we let go of the device, we actually use more echo, because normally we take pictures in the artery so we can see these things, but we don't touch the artery in these babies. I mean, this baby weighs about probably between 1 and 2 pounds. So we just can't, we can't take the risk of hurting the artery, so we just do everything through the vein. We take some pictures. These are the pulmonary arteries, making sure that, well, pulmonary arteries are there, the PDA should be right there, it's not there. We're pretty happy, we think we've done the right thing. And then we're able to release this device and just kind of stays in place, and we're able to pull everything out. We can do this procedure in about 20 minutes. And since we started doing this, we actually we closed very, very few PDAs surgically. These were all done surgically. We were doing all the older kids, not touching the small kids, but now we can offer this very important procedure, because in these kids, they get really sick by having a PDA. If you've had a child, or if one of you had a PDA, you were probably healthy going into the hospital to have it closed. And these kids are kids that are on ventilators that can't get off the ventilator, and this can be the reason they can get off the ventilator and ultimately go home, which is what we all want. Another innovation is another common, much more complex heart disease, pulmonary atresia. And this is a different variant than some may have had, where they don't have a ventricular septal defect, it's intact. Previously, the only way you could do anything here was do surgery. Sometimes they would go down the pathway of the Glenn and then the Fontan procedure, but we really would like to be able to use the ventricle if it's possible. And so a procedure that was designed was, can we open up the valve? If the valve is kind of a plate and it just isn't open, it's just more of a plate instead of a valve leaflet, is it possible? And so actually, that's the plate. That's where the valve should be. And this ventricle, and I feel bad because it's a great kid, it's really ugly ventricle. It's really not what we want to see. It's a lot of muscle. But the story has a very happy ending. So what we do here, we're in Texas, so we get our lasso out, and we put that lasso on the other side of that valve so we know where it is, and we introduce a wire that we apply heat to. And so actually, Mr. Montgomery was talking about the procedure he had. It's a similar technology, and we just burn across that valve. We grab a hold of that wire, and then we can introduce a balloon and open up the valve. Now, in this child, the right ventricle was just not working very well, and this wasn't enough. So we were frustrated because we were afraid, well, we may not have been able to avoid surgery after all, but what we decided to do instead is we put a stent in the PDA. So instead of closing the PDA, we put something in to keep it open, so that PDA could allow additional blood to get to the lungs while we let the right ventricle do better. We sent this kid home. About 18 months later, the kid came back, and one of the stents still worked because the PDA was still open, so we actually put a device in, closed that PDA. This child never had surgery. Another common kind of complex heart disease that we deal with, tetralogy of Fallot. I'm pretty sure there's somebody here that either had that or was infected by this disease. And well, unfortunately, I'm going to tell you, we can't fix this one. But sometimes these kids, they need something done early on. They're not all able to have a definitive surgery early on. And so the most conventional would be a surgery, a placement of a BT shunt, like Taussig shunt. More recently, more and more centers are starting to put a stent in the PDA to keep it open, kind of like I showed you with that last video. But in some children, the PDA closes and then you find out you need it, you can't get it back open, or it's too difficult. So in the ones where you don't feel you're going to be able to salvage the valve, yeah, this was first done in Toronto. The idea of just putting a stent across that outflow tract is to keep it open so that they don't have the tent spells or the cyanotic spells. And so here's an example, a lot of muscle, and really the big problem there is the muscle underneath the valve. And so we introduce a stent, open that up, and kind of keep that muscle from clamping down. Yes, it is crazy. I heard someone call me crazy. That's okay. We are crazy. And it's open, and then blood flow is able to get to the lungs, helps the lung arteries to grow, pulmonary arteries, and ultimately, when the child was older, able to come back for surgery and get a full repair. Now, the area that I'm really excited about, this is, as much as some of what we do seems competitive with our surgeons, for me, I look at them as collaborators, and there's nothing more important to me than the concept of what we call hybrid procedures. Some people think of hybrid procedures as one procedure, but really anything for me where we use the skills from the cath lab, the skills from the operating room together is a hybrid procedure. And here's one that is actually one that was it's a lot of fun to do. It's called the perventricular VSD. And the reason why it's great is because it really emphasizes the teamwork that takes place in the heart center, where you have a large ventricular septal defect. It's very low in the heart, very hard for a surgeon to get to, get past a lot of muscle and bands. For us, we have devices, we can get to it. The problem is when they're really small, the child gets really unhappy when we're in there kind of trying to get that device in place. And so where's the happy medium? Well, the happy medium is actually if you can just go right through the wall of the heart and close the defect. But if you make a big incision, that produces its own problems. So what we've been able to do is it is a surgery. They do a sternotomy, like many have had. But instead of putting the heart on bypass and stopping the heart, we just let the heart keep pumping. And we just put a needle right in through the heart, introduce our catheter. We don't make an incision at all. We just dilate that little hole from the needle, put our across and introduce the device. And here's actually a video of that. And so basically, this is just sticking. I hope people don't have a weak stomach. Sorry. And this is this is all done by echo. And so we see the wire crossing the heart. Really doesn't like that wire being across there. And then we introduce the sheath. So if you've ever had a heart cath, this is usually what goes in your leg. We're just putting it directly across the heart. And then you'll see what looks like a straw crossing on the echocardiogram that we put the wire on. There it is. There's our straw crossing that defect. Then we get our device, get that prepared. And we just introduce it down there through the straw. And here you'll see the first disc kind of pop out. And we'll pull it up against the septum. Finish the release. And then we're great. We have echo, so we can interrogate it, make sure we're happy with it, make sure it's doing its job. And once we're happy with it, we unscrew the pin and we leave the device behind. And the one thing that the surgeons do to help us out is they put these little sutures right around where our sheath goes. So, and you'll see this here in just a second. As soon as we're done, there it is. We release the device, and as we pull it out, they have the little sutures right there on the wall of the heart, just like little purse strings. As soon as that comes out, they pull it, and it's it. Probably lost 2 millimeters of blood there, and that was it. And the end is closed. And what I think is great about this is that this is something that you don't have to just relegate to these advanced centers. I see it as something that is more when I do a lot of overseas travel, doing medical missionary work, and we can teach these young surgeons and interventionalists that don't have the experience, instead of teaching them how to do things that are really, really hard, why don't we teach them something that's really, really easy? It's easier for us. This is a 20-minute procedure. You know, this is a 3 or 4 hour catheterization, and it's probably a several hour surgery. It's a 20-minute procedure when we work together. And this is us in Kharkiv, Ukraine. This actually had 2 defects, so we put 2 devices in simultaneously. That's why you see 2 sheaths there. And this is the young man there. There's his 2 devices sitting in his heart through the x-ray. And this is us in Santa Cruz, Bolivia. It's actually my former surgeon, Dr. Douglas, who recently left us, and that's actually Dr. Pignatelli, who actually works here at Texas Children's. This is a collaborative mission that we've been doing with Texas Children's for the last 12 years. We just got back last week. And then here I am in Kampala, Uganda, with the team from my former employer in Indiana. Again, teaching these surgeons and interventionalists to be able to do procedures like this and offer this to children. This is something that I think creates a lot of excitement. Anyone that has an RV to PA conduit or has had a valve implant or have had multiple of the same, now that's not necessary. Sometimes you won't need any conduit, or if you have one conduit, that may be the only one that you ever need because of this technology. This is the Medtronic Midi Valve, the first one that was developed. This is actually a cow's jugular vein. Get the vein out, the neck vein out of a cow and sew it onto a stent, and you have your Midi valve. Before you think we're too barbaric, conduit, it's the same valve. It's just done surgically. This is the Edwards Sapien valve. This recently received FDA approval, and this is basically using the pericardium from a cow and creating leaflets and sewing them into this stent. It allows us also to deliver. And the nice thing is they're not completely competitive products. The Midi valve goes smaller, the Edwards valve goes bigger. And so really it just gives us a broader selection of what we can use. And this kind of just showed you how these work. You can see the stent around it, and there's the valve opening and closing. So it's really a wonderful technology. This is actually a young girl that came, she had tetralogy of Fallot, had it repaired. Unfortunately, her valve was no longer working, it was leaking, she was getting hospitalized all the time. Beautiful little kid. And so we put a stent in, and then this is actually the valve going in. Just blow that up. The nice thing is, instead of this just being something that keeps it open, here's a picture of it, and it shows nothing comes back. So, and she hasn't been in the hospital since. So wonderful, wonderful outcome for this little girl. And I told you I love hybrid procedures. So sometimes this technology doesn't work. Let me give you an example of that. There was a 27-year-old lady that came. She actually came from back east, tetralogy of Fallot, and she thought she was fixed. Quit seeing doctors for many, 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 many years until she was 27. And then she was just fatigued. She didn't have any energy. And the problem was that because of religious beliefs, she didn't want to have a blood transfusion. And it's something that, we try really hard to respect people's beliefs and backgrounds. And it's really very hard to do surgery and replace a valve without using blood. And so we thought, well, we've got this valve. We can help her. So we had a CT scan that was sent to us. This was actually in collaboration with my dear friend, Dr. Lynn from Houston Methodist. So yes, we do compete, but we're actually friends. And so Dr. Lynn and I decided, hey, we think we can do this. We have this CT. And unfortunately, the CT didn't tell us the whole story. And so we brought her in, and this was the problem. That's a balloon that we put in to size the area. That's the size of the largest melody valve. But even with contrast injected, we can see it going to the lungs. We weren't getting a valve to stay put. We put a valve in there, that's going to be floating around in her ventricle. And we were demoralized. We had to wake her up and tell her we were really sorry, but we really couldn't do what we had set out to do. But we hadn't given up yet. And so this is where technology comes into play. We said, well, let's play around with this. Now it's her heart, so we can't really just take her heart out and play around with it. So we took the images that we had and we created a 3D model of her heart. Because the model was something that we could play around with and figure out what we could do. We could test different options. And so what we did is we then scanned her heart, put it on the table, and we scanned it in the cath lab, and we created some imaging, and then we're able to kind of mold the images together so that we make sure that there was a one and the same. Then we were able to do things like place a balloon inside the model and kind of see where to pose. And one of the things that we saw was it barely touches the sides of that main pulmonary artery. And this is just some of the imaging of that. And I'll get through this because otherwise I'll be talking forever. So we came to the conclusion that we needed something new. We knew that we couldn't do bypass. We knew we needed to minimize blood loss. We knew we needed to get a valve in there somehow. And we knew that we were going to need our surgical friends. And so what we did is we did a sternotomy. The surgeon put a felt band around that main pulmonary artery. We put a balloon up. We sized the pulmonary artery to make it the size of the valve. So we brought it to the valve instead of the valve to it. And then because we're in the cath lab, we have to be able to see things. So we put a little string that was something we could see. So we knew exactly where it was. And then we introduced some stents to kind of create a landing zone and then place the valve. And just show you some, this is the surgeon kind of opening up, freeing up the pulmonary artery. That's actually the string that we're going to be able to see in a minute. And then they've now secured this little band around the pulmonary artery to make it the right size so that we would be able to get the valve in. So here's an image of, you can see there's that band, so we knew exactly where it was. And then here we are deploying one of the stents right in that space. Actually, while we turned around to put get the melody valve ready, the surgeon just put a little stitch in it just to make sure it wouldn't go anywhere. So see, they look out for us. And then this is us deploying the melody valve. And then again, like the prior picture, nothing leaks. Now the nice thing about this is at Houston Methodist, they have this little, kind of a fun little toy that measures all the blood loss, like very specifically. We lost about 5 to 6 teaspoons of blood in the whole procedure. Her hemoglobin didn't change at all. Post-op echocardiogram, perfect. Went home 4 days later. It's just because we can't do this for everybody. This is actually the next generation. This is the Harmony valve. Just so you know, Melody, Harmony, the person who developed this is an interventional cardiologist who's also a concert violinist. So that's where it came from. So this is the valve that will allow us to get into these larger places, and even Edwards has a solution of their own that they're working on. So again, we're going to talk about hybrid again, atrial septal defect. Some may have had an atrial septal defect closed surgically in the past. We close a lot of these now in the cath lab, but the ones that we're closing are these ones, the secundum ASD. It's these ones that we really can't close. But the sinus venosus defect, one of the reasons we can't close this one is because sometimes the vein that comes back to heart, the pulmonary vein, instead of going to the left atrium, comes in right before that septal defect into the superior vena cava. And if we close that defect in the cath lab, then that vein doesn't go where it's supposed to go. However, an older man came to us, a 63-year-old, and guess what? He has a sinus venosus defect. He had bigger problems. His bigger problems was that he had liver cancer and cirrhosis of the liver. He needed a liver transplant. His problem was no liver transplant surgeon was going to touch him with the heart defects. Other problem? No heart surgeon was going to touch him with liver disease. So nobody wanted to touch this poor guy, and so we decided maybe we need to kind of figure something out for him. So we had to come up with a very extensive plan. There was as much planning going into it as there wasn't actually doing the procedure. And first thing we did is we did some imaging, figured out where everything was. This is where the SVC is, superior vena cava, where the defect was. This is where things came into the heart. And we just had to make sure we knew where everything was. And this is just the image, and you can see how we can draw these little regions of interest relative to the image that we have. Then we made a 3D model of his heart, and this model was a soft model so that we could actually manipulate it so that what we did to it would be somewhat similar to what we would do to it in real life. We then had to register it, had to make sure that the model and the heart were one and the same, so this is just us playing around with the different imaging. Then we had to come up with a method. We couldn't just use any device, and so we came up with a stent that's called the Indurance stent. It's a covered stent with the idea that we could introduce that stent and kind of wall off that defect and see if that pulmonary vein would course right behind that stent into the left atrium. And so again, we did some sizing, kind of figured out based on our imaging what we had to deal with, what our diameters were, what our lengths were, and then we decided, okay, well, we're going to do it first on the heart, on this model. And so here we are releasing the stent in the model itself. Of course, it's not beating, and we'll have to deal with that later. And this just shows kind of the imaging we did afterwards, and we could see, here's our stent, and here's our pulmonary vein, and look at that. There is space behind it, and there's the left atrium. So there was hope here. Here's a chance we were going to be able to do something that was previously only done surgically. Maybe we could do this in the cath lab. And don't forget, actually, we had a surgeon there, so we kept our collaboration with them. And so here we are. We did some imaging, making sure that everything was what we wanted. We can kind of see as we move through the different planes where the device is. There's some different imaging that we can do, kind of rotate things around, make sure everything is exactly as we want, and then it's time to bring the patient in. So this is days and weeks of work. The patient's at home. So it's time to bring them in. So you bring them in and you do some more imaging. You get a patient on the table, do some scans, and you can see if it starts. You can kind of create a rotational image to kind of see where all the structures are so that, again, we can register it and kind of figure out where everything is, because you really have to be precise. If you're a little too high, you're covering things you don't want to cover, or you're missing things that you want to cover, so you don't have a lot of room for error. So we go in, we put a balloon in, make sure the balloon is about the size of the stent so we know it's going to stay in place. And then we introduce the device. So this is actually our surgeon pushing it in this is another collaboration with Dr. Lin, and pushing the device in place. We make sure that we're getting all the way down to where the right atrium is. We're not covering this vessel up here. Here's the hole. Want to make sure everything's where we want. Take some pictures with some contrast. And then it's time to, after all this work, here's the moment of truth. So the device is released. And then we can take our picture and we can see blood going right down the SVC into the right atrium and nothing going into the left side. Makes us happy, but really the real moment of gratification was we have a catheter up in the right upper pulmonary vein, and there it goes into the left atrium and nothing. So the defect was closed and we preserved the right pulmonary vein. So again, this is just this follow-up that everything is working. So really what this is, it's a matter of applying existing tools to a new challenge using 3D models as a great way for us to be able to practice. And that sounds horrible, but it allows us to be able to figure out what we're going to do before we do it, make sure we do it right. And I think that it's also going to lend us to be able to do things we go in not thinking we could do, but because we can prove it before we know what we can accomplish and maybe offer even better solutions for the children. So I just want to talk just the last couple of minutes about future therapies, because everything I just showed you is today. We can do this stuff today. One problem we have are vessels that are too small, and we need to make them bigger. And we can use balloons, but they're not perfect, and in some ways they have certain dangers involved. So we have stents. And I wish Dr. Fraser was still here to talk about, I know Dr. Fraser hates stents. In fact, most surgeons hate stents. We put stents in and they just get in the way if they have to do surgery again. I get it. And I actually very much respect that. And so one of the things that we need, though, is we need stents to make things open. But we also have the problem that our children grow. If I stick a stent in, the child grows, the stent doesn't. So then what do you do? And so one of the great technologies that come out are bioabsorbable stents, so things that go away. They only stick around for a few months to a couple of years, and then they go away. This would be perfect for our patients because our kids will grow up, and by the time they grow up, the stent's gone. If they need another one, put another one in, but then let that go away. And this is actually the only FDA-approved one that unfortunately was recently taken off the market because it was put in for coronary artery disease. And it didn't work. It will work for us. And it's devastating to us to see this. And again, it's the same thing. Everything gets made for adults because there's so many adults and their diseases are kind of similar. You know, every one of you out there that, right, everyone that have children that have heart disease, every one of your children are very, very unique. Not just unique because of their personality and because how cute they are, but because there's something very unique and different about their heart disease. And it's hard to make things for us because there's just no market for it. They're making it for a very tiny population. But we're very hopeful that we can still use this type of technology. And here's an example where it can be done. This was a child that actually had a PDA ligated surgically. Unfortunately, the surgeon got the wrong vessel and closed off the pulmonary artery, not the PDA. Oops. And the problem is the pulmonary artery didn't like it even when they took the clip off. So they put in a biodegradable stent, one that was meant for coronary artery. Again, we kind of use it how we want to. And they were able to reestablish flow to that. That stent will go away. And then they'll have their blood vessel back. Here's an example of one of my colleagues in Germany, Dr. Schantz, who, again, here's a coarctation of the aorta. This is what I'm really excited about. All these kids, if you're a teenager or even an older child with coarctation, you come to me, you're going to get a stent, you'll never have a surgery. We can't do that with these kids. There's no stent I have that's going to help this child at this point. But you put in a biodegradable stent and was able to take care of this child when they were actually a 1,800 gram infant. So that's what, about 3 pounds, 3.5 pounds. So in summary, we have a lot to offer our patients, and more devices and more ways of approaching it are being developed all the time. We're getting smaller and smaller so we can treat younger and smaller patients. And we really hope to continue to provide options that improve what we can deliver with making our tools better and with working with our surgery colleagues to offer you more. I just want to put in a little plug for the first annual Congenital Heart Walk on October 21st. We certainly hope this is actually something that's being sponsored by Texas Children's, Houston Methodist, Children's Memorial Hermann. We hope that that all our institutions hope that we can get you guys out there, form teams with you and your families, and come and join us. Thank you.
wants to get up and just stretch for a second, that'd be fine while I get my slides. I know it's been a long session. Hi.
That's yes.
Sure.
You all, we're not going to do, Dr. Fraser had to leave, and we're not going to do questions after this panel. It's running a little long. And I know Katie Dodds needs to catch a plane, so she's going to go first on the next panel. So we're going to keep going. I'm glad Dr. Karen Malou said take a little rest break. But we're going to try to get everyone back in pretty quickly and keep going, and then we have a great lunch for you. But get up as you need to. Don't just sit here because you feel like, you know, you have to. Just get up as you need to, stretch. You can stand against the walls. You can use the restroom, obviously. Sedation.
Yeah.
I'm going to get coffee. Okay.
How are you doing today?
Good. How are you?
I'm wonderful, thank you. Way better today.
Were you tired yesterday? Yeah. Did you fly from somewhere far?
No, I live here.
Oh my gosh, you were just tired?
Well, we started working at 5:30 yesterday morning, and then I finally got the DJ packed up at 10:45, 10:30 last night. So it's just a long day. But
What was all the boxes of all the supplies? That was really cool. Were we supposed to bring stuff? If I would have known, I would have gone out and bought it.
oh, it's okay. No, we've so we do the bravery bag program. So every child that comes to any of our hospitals gets a bag with toiletries, the Mended little book guide, which has information for the parents, and a ton of information. The kids get a little tiny stitch, the CHD lion.
Yeah.
And he comes with a birth certificate that you can fill out, so they have
Like
their,
a Build-A-Bear.
yes, like they have their surgery information. And oh, so we were making bravery bags, but also we made care bags for heart patients. So we're
Okay, I think just because we're running late, I'm gonna just get started and then people can file in. So thank you for giving me an opportunity to talk a little bit about this topic, which is through the looking glass, new ideas in old concepts in mechanical circulatory support. And I want to just acknowledge some of my colleagues at Phoenix Children's Hospital who have allowed me to use some of their data and some of their slides. I have no disclosures. So sometimes I think we all feel a little bit like this when we wake up in the morning. Let's do something exciting today, and why would we ever want to do that, right? Okay, so some of you might be wondering about the title of this talk, Through the Looking Glass, and why this theme. And so by way of answering that question, a brief digression. So some of you may know the gentleman, Charles Lutwidge Dodson. Does anybody know who that is?
Lewis Carroll.
That's right, Lewis Carroll. So most of you will know him by his pen name, Lewis Carroll, and his most famous work, of course, is Alice and Her Adventures in Wonderland. So who's read the story, seen the movie? Anybody, especially the new Johnny Depp ones? A lot of people. So his literary works are couched in a genre called literary nonsense. And literary nonsense is a genre of literature that balances elements that make sense with some that do not, with the effect of subverting language conventions. So what does that have to do with medicine? Well, a lot of what we do every day in medicine is literary nonsense. Some of it is based on anecdote and it defies all logic. We just do it because that's what we've always done. And some of it is based on real empiric data. So through the looking glass, then, it's a metaphorical expression, and it was coined in 1871 by Lewis Carroll in his follow-up work to Alice and Her Adventures in Wonderland, and this is called Through the Looking Glass and What Alice Found There. And what it means is, on the strange side, backwards, as if looking through a mirror. But there's an alternate definition, a reference to a classic or historical work that reflects on contemporary experiences. And so today, what I'm going to talk about is moving through our looking glass in congenital heart disease. And what I mean by that is that we're going to integrate knowledge from the past and things that we've learned to try to take better care of our most complex patients. And I would argue that those are patients with heart failure who need some type of support. So the agenda today, we're going to talk a little bit about the scope of the problem. And I think Dr. Fraser talked a little bit about how many children in heart failure admissions and what their outcomes are. We're going to talk about care for congenital heart disease and mechanical circulatory support, and especially those with single ventricle support. And then I'm going to talk about our looking glass to improve care at Phoenix Children's Hospital. And I'm going to talk about 4 things. 1 is our experience with the total artificial heart. 2 is virtual implantation. We've heard a little bit about 3D models. 3, smaller devices and more options. Everything is small, small, small. And then finally, resurgence of ECMO as a bridge. And I think it's an interesting concept. So Dr. Fraser talked about this. We're not going to belabor it. How many parents or people in this room have single ventricle disease? Okay. So a lot of them. And as you know, it's a bunch of surgeries staged over the life of your precious child or yourselves or somebody that you know. And it's a lot of surgery. So what is the scope of the problem? Anybody here a transplant recipient or had a child or anybody who had any type of mechanical support, ECMO, VADS? Okay. So the outcomes, there's a lot. So every year, 55% of babies under 1 year of age undergoing transplant require some type of mechanical support. And 29% of those need either ECMO or a VAD. And ECMO doesn't really have a great name because of this, that patients with single ventricle disease often can't be supported with VADs and they need to be supported with ECMO. And the results with single ventricle patients, they have the highest mortality and they have the highest waitlist attrition. Okay, so sometimes you wake up and you feel like this, right? Why can't I just get to where I want to be quickly? But you got to go one step at a time, and that's what we do as practitioners. We have to build on other people's discoveries and other people's knowledge and try to move forward every day. So I don't want to go through all of these in detail because that's not the point of this talk. You don't need to know what the difference between a PD mag or a CentriMag is necessarily. What I want you to take away from this is that there's a lot of things that we have available, but as we've heard, most of these things are designed for adults. So people don't spend a lot of money because there's not a lot of children compared to adults with heart failure. And that's something that Angel and I have talked about, trying to build support so that we can innovate in pediatric disease. These are some of the different options for short-term mechanical circulatory support. We have the Rotaflow, we have the hardware, we have the Impella, lots of different devices that we can use for short-term support. There's a lot of different options for long-term support, but again, really, most of these devices, with the exception of the Berlin, designed for pediatric patients. So how many of you have gone, I'm going to talk to the girls in this audience, how many of you have gone to Sephora and looked at all the makeup and different things for your face, and you look there and you're like, oh my God, what do I choose? There's so many things, and they're all supposed to, get rid of wrinkles or whatnot. What do they do? It's overwhelming. But I would argue that it's not so much what type of pump you choose, but it's when. It's really a question of timing, okay? So I want to show you a couple of slides, and you don't have to be a statistician to understand these. I'm going to take you through what they mean. Right here is the risk of mortality, okay? Or the good word is death, okay? Your risk of death is going up here. It's either 100% or it's 0%. So you want to be more down here. And then this is the days between when you had some type of mechanical support, okay, and your transplant, okay? And this red line is the risk of death after your transplant. What that means is that if you get your transplant early, and the lowest point here is about 40 days, you do the best. So what I want you to take away from this slide are two things. Number one, that you can use mechanical circulatory support as a, quote, bridge to transplant, but you got to do it early, okay? And you also have to get the patient then listed and try to get them transplanted. Okay, what about these slides? Well, this just shows why do we use VADs or ECMO? Does anybody know? It's like a school teacher. Why would you put somebody on some type of mechanical circulatory support? Yeah, to buy time, to get their heart working. Well, you might not get their heart working, but you'll get their other organs working, right? And that's what we do when we put children onto either ECMO or onto circulatory support. We're trying to get what we call as practitioners end organ function recovery. So kidneys, we heard yesterday an amazingly inspirational talk about a woman who had multi-organ transplant, heart, lung, and kidney, right? Her kidneys weren't working, her lungs weren't working. And so what we do is we try to use a device that can augment cardiac output, okay? So here is bilirubin. Bilirubin is something that the liver basically makes, and the liver is also an organ that gets rid of some of the waste products. Creatinine is something that our kidneys make. So these two graphs talk about how well your liver is functioning and how well your kidneys are functioning. So this just shows that if your bilirubin is going up or your creatinine is going up, your risk of death is high. Okay, so we've got to try to do everything we can to support those organ systems. So what about ECMO? That's the easiest thing, what we call it's easily deployed. That means we can do it quickly. And it's safe, usually for about 14 to 28 days before bad things start happening while you're on ECMO. Bleeding, strokes, things like that. There's no size restrictions. We have a whole bunch of different cannulas, which is just a fancy word for tubes that we put into the large veins or vessels in the heart so that we can bridge them. And it can be a bridge to transplant or even what we call a bridge to decision. So if you're not sure that a patient can be transplanted, or maybe you think if they're a cardiomyopath, so they don't have complex congenital heart disease, but they have either a big dilated heart or a very thick heart, maybe that patient might recover their heart function. So not every patient that goes on to some type of support is going to need a transplant, okay? So bridge to decision. But as I mentioned, ECMO has a bad name in mechanical circulatory support, and I'll show you why in a minute. This is a slide that Ryan Davies put together, and it's published in JPCBS. Just shows the number of pediatric transplants, and then mechanical circulatory support is these hatched areas here. This line just kind of shows how it's up and down. Okay, so it's kind of been all over the map in terms of how much we've deployed using VADs in pediatric patients, but what's kind of interesting is that the transplants have gone up over time, okay? So does anybody know what kind of, these are called survival curves, and you might have seen some of these. But again, what these show is that this is now survival, okay? So you now want to be up here rather than the death slide. So the good survival is 100%, bad 0%. This is years after transplant. These are the different types of support devices that we can use for children, okay? What this shows is that patients on ECMO, they didn't have as good survival. At 2 years, they were only about 60%, whereas if you had a VAD, you were about 80 or 85%, and the difference between these two curves, that's pretty small. Did you have a question?
Do you know children with Down syndrome who have repair? How likely are they? Are they like regular CHD children, or are they more likely to not recover as fast? I'm asking for other families who have Down syndrome children.
Sure, that's
And children with different arms.
a great question. So children with Down syndrome, does a lot of families have children with trisomy 21 or other type of congenital or chromosomal syndromes? Okay, so Down syndrome is actually in some ways good and bad. What I mean by that is there are some types of congenital heart disease like AV canal, okay, when you have two common valves. Patients with Down syndrome often have what we call favorable types of AV canal, so they actually do better than patients without Down syndrome. When it comes to transplant and mechanical circulatory support, a lot of babies with Down syndrome are not necessarily represented in this because they don't often have the types of heart disease that result in the need for transplantation, okay? But in general, patients and children with syndromes and chromosomal abnormalities tend to fare worse overall, okay? What we say is that it's a risk factor. It's a risk factor for a lot of bad things to happen, but we can talk a little bit more offline. There's certain specific things where those patients actually do better. Okay, I hope that kind of answered your question. And yeah, just feel free to interrupt me. My husband does it all the time. Okay, so let's go a little further down the rabbit hole, okay? Going on with the Alice in Wonderland theme, where as Alice says, curiouser and curiouser. To talk about single ventricle support. So Berlin hearts, those are the only really FDA-approved device for young children. We can use it as small as children, 3 kilos. We talked a little bit about it. I want to just look at these two sort of sobering statistics Again, if you have single ventricle disease, you are only bridged successfully about 42% of the time, okay, compared to what we call biventricular patients, those with cardiomyopathy, et cetera, 73%. This is also pretty sobering. Remember I talked about how you might recover your heart function? Patients with single ventricles, none of them recovered their function. Okay, and that just means that if you come to needing mechanical support as a single ventricle patient, you're not going to get better without a transplant, okay? So what is this? Well, these are complex graphs, but what you need to see here is this is a single ventricle patients, and the green line is what I want you to look at. This is the two ventricle patients. This green line is the amount of patients who got bridged to transplant successfully. So again, 60+% for the cardiomyopathic patients versus 42% for the single ventricle patients. So again, we talked about this. There was a lot of hands that went up when I asked, do you have kids with single ventricle disease? And a lot of you said, yes, I do. My son, my daughter, my mom, my dad. Okay, those patients don't do that well. Okay, so innovation. This is a cool graph. Who reads Malcolm Gladwell? Did anybody read Malcolm Gladwell's Tipping Point? Okay, so Malcolm Gladwell, he came to lecture when I was at UCSF, and I got to have dinner with him, and it was like the highlight of my life because I think he's a genius. And he talks a little bit about this phenomenon, so tipping point. So some of you might remember like James jeans or like Gloria Vanderbilt jeans back in the 70s, the bell bottoms, like those things got to a point where everybody had them, or Cabbage Patch dolls. Everybody needed to have a Cabbage Patch doll. Well, congenital heart disease and innovations that we've talked a lot about are just like that. There's a tipping point where this boom phase where everything is new and it's sexy and we want to have this new device. We heard a lot about ASD devices and PDA devices and all these different things we can now put into babies and people's hearts. But we have to be pragmatic and we have to be conscientious about the use of these things. I'm not saying that we shouldn't embrace new things, but we've got to do it with some circumspection and some caution because there's problems, right? I mean, Teslas are really cool and then they have some problems. So you might not want to be the first person that adopts it. There's a disillusionment phase where you find that everything has some problems to it. But you can refine the techniques, and in our world, it's patient selection, right? We learn iteratively that patients with large outflow tracts might not be the best candidates to go for transcatheter valves. Maybe we ought to keep those patients in the operating room. As a surgeon, that's where I think a lot of these patients belong. I'm a little bit biased. But then when we get this right, and it's about getting it right and finding what the best technology is for your son, your daughter. Not everything can just be applied to everybody, okay? It has to be what we call precision medicine. That's what we're striving for, individualized care for your child. Then we enter the niche phase where, you know, not everybody looks good in bell bottoms, but there are some people who can wear them really well. Okay. All right, so I want to talk about some just cool things in the single ventricle pipe. There's a surgeon called Mark Rodefeld who's done a lot of work in this. There's a lot of people working in labs and things to develop single ventricle support devices, and some of these are kind of interesting. So this is a little device that you put in, and it's got a little axial rotor in it where it then spins and it gives blood to your pulmonary arteries. So if you have a Fontan and you can't get blood from your IVC because your heart's not working well or your pressure in your lungs is too high, this little device is a pump that actually augments your Fontan. So that's, I thought, kind of interesting. This is another type of device. This just shows what it sort of looks like. It gets delivered percutaneously. It sits in your IVC, okay, and then it spins around. It has this impeller and a diffuser, which takes the blood and then gives it to your pulmonary arteries. This one I thought was really neat. This is a pneumatic compression device where you put this thing and wrap it around the Fontan, and it times it with your EKG, and it expands and contracts to help propel blood through your Fontan circulation. That's kind of interesting. What about this one? It's very similar. This is called the Fontan Circulatory Assist device. Same thing. It gets positioned where it augments blood flow through, this is a magnetic device, just like we heard about from Dr. Fraser, and then it gives it into your SVC. These are for Fontan supports or for Glens, which we know we don't have really good options for. Okay? So finally, I want to talk a little bit about a story of one of our patients at Phoenix Children's Hospital who had a total artificial heart. And I think it's a great story, and it talks a little bit about innovations and how we have moved through our looking glass at Phoenix Children's Hospital. I want to give some props to the folks at Syncardia because they're doing a great job innovating for women, right? I mean, a lot of women are not that much bigger than some of our patients, and women need better things too, okay? And I'm speaking as a mom and as a wife and as a woman. So these are some of the innovations that the Syncardia folks have brought to us. This is a portable freedom driver, they call it, where you can go home, and this is a backpack. You put your battery in your backpack, and this is the 50cc total artificial heart, which is a smaller device than the 70cc pump that they have. Okay, so let's talk about this kiddo. He's a 14-year-old boy. He weighed 50 kilos, and he was a patient who had 2 ventricles. So he was a slightly better than risk than some of our single ventricle patients. His heart was not working well, but interestingly, he had something that prevented us from deploying normal types of support. He had clots in his heart, okay? So when we put these devices in, if they've got clots in their heart, you know, the heart is wonderful because it has a way to line the surface, and it also has relatively big outflows. And if you remember back some of those slides we showed with the artificial pumps, they're not, the diameter of these things is not that big, and they're also thrombogenic. So if you put them into somebody where they already have clots, the device is going to get plugged up, those clots are going to go to your brain, to your kidneys, to your liver, and really it's not going to be a good outcome. So we all got together and we thought, we can't really do this. We got to get rid of the source of the clots, but the source of the clots was the heart. How do you get rid of the heart? Well, you got to replace it with another heart. Well, transplant doesn't work that way. I don't just say, all right, I need, you know, a type A transplant, let me go to the shelf and pull one off. As you know, it takes a long time, and unfortunately, couched in that is that the donor has to die to give a heart to somebody who needs it. So that luckily doesn't happen every day. Okay, so the other problem was that there was only 9 centimeters from the back of your spine. When we look at these things, like, you know, you can kind of see, how is something going to fit inside a small person? It has to be, you have to have a wide enough thoracic cage. And this is what his heart looked like. It was pretty big, obviously. And this is just some pictures of us doing the implant. So you can't really see it as well here, but we had to, basically, these were all the clots when we opened up the ventricle. Okay, so the only way to get rid of those was to get rid of the ventricles. And luckily, with the total artificial heart, you can replace the ventricles with the pump. This is the, you can see a little bit of the pump here. These are just the tubes that keep the patient on the heart-lung machine before this total artificial heart starts working. And this, now, so the kid had the total artificial heart. We put it in. He was recovering from surgery. But look at this chest x-ray, right? So it's like pattern recognition. Something's wrong here, right? There's a bunch of white space where there should be black lungs. So we put the total artificial heart in, and the child was not doing that well. And this heart and these lungs didn't look good. So then we started wondering, why does it look like that? So does anybody have any ideas? People have been in the hospital and their child's lung didn't look good. Did the doctors give you any ideas of what that might be? Effusions. Okay, good. I feel like a school teacher. What else? Atelectasis. Okay. So this is where I think innovation came in. We've heard a lot about 3D imaging, and we use 3D imaging and 3D printing. This is a 3D print and the thoracic cage that Justin Ryan, who Angel knows, one of the scientists who works at the 3D print lab at Phoenix Children's Hospital, makes these models for us, and we use this in 2 ways. One, we could simulate or virtually implant the total artificial heart inside somebody. So we didn't have to say, is it going to fit? We actually could model that, and we were able to say, look, he might not have had 10 centimeters, which you're supposed to have. He only had 9 centimeters, but we virtually implanted this heart inside his thoracic cage restrictions, and we found that the heart would fit. So we were confident that we could get the heart to fit. Second, what did we do? Remember that chest x-ray I showed you? We were worried because that total artificial heart can compress structures, like the pulmonary veins that come back to the left atrium, or like the bronchi, which are our airways. Those things can get compressed. So we used the 3D printing and the 3D modeling to show us that the veins were okay and that the airway was okay. So then we knew, okay, this isn't compression. We have to start looking at other things to do. And currently, I just want to mention this because Dr. Ryan and our team, we've now done 102 of these virtual implants for the total artificial heart. So there's a multi-institutional trial that we're involved with that spans 7 countries. And if you want any more information about it or you want to get involved in it, which is a fabulous thing, just visit this website. And we're really excited about it. So this is the kiddo holding the model of his heart. This is after his transplant. So he was successfully bridged. We deployed the total artificial heart, and he got transplanted 12 days later. And he's doing great. And this is his chest x-ray now.
Just a really quick question. I know we're short on time, but I've heard that it's easier to do in a single ventricle to put that in first because then you have the setup for the heart with 2 ventricles. Is that true, or is it just as well with the virtual heart?
I think that's a great question. So with single ventricles, I think the total artificial heart is in some ways superior to that because it gives you a 2 ventricle circulation, most importantly, so it may support end organ recovery. Remember we talked about the kidneys and the liver and the things that aren't working well. If you have 2 ventricles that are pumping to your body in a pulsatile way, right? You know, you take your pulse and you have a pulse, right? Okay, and so that's normal. Some of these pumps that are centrifugal pumps, they don't have their pulseless, okay? Things like the initial, LVADs for, heartbeat 2s that we use in older children or adults. Patients don't have pulses with those. That's not really a normal circulation. Your organs are used to seeing a pulse. So yes, that may be true. I think the other thing with the total artificial heart is that Berlin heart has not been as good for single ventricle patients. I showed you some of that data. So we haven't been able to bridge those patients as successfully. There's some problems with that. But the total artificial heart comes with its problems too, meaning that the smallest BSA, we won't be able to do babies with the total artificial heart, which you will with the Berlin. But I think this is just wonderful, and what a beautiful child. Okay, so this is really interesting. This is Alice Liddell, circa 1858. That's the Alice that Lewis Carroll wrote about in Alice in Wonderland. And she was actually the daughter of the dean of his school. So they were childhood friends. And I thought this was wonderful. Anybody who has teenagers can relate to this. She generally gave herself very good advice, but she seldom followed it. So true, right? So I only have a couple more slides, and I want to show this slide because it always reminds me to end my talk with the thought that just because you're a hammer, everything isn't a nail, okay? And sometimes with some of our sickest children, sometimes the most compassionate thing is actually not to do anything, okay? And that's something that we have to remind ourselves as surgeons, as interventionalists, to always take all of the possible choices and respect the patient and their comfort and their quality of life is the most important thing, okay? So what this is, these are histograms. These are all hospitals, okay? Hospitals all throughout the country. This is the proportion of newborns that are managed with one of these 2 types of strategies, okay? We talked about transplant, which is the pink. So hospitals that do transplantation are shown here. Norwoods are in green, so some hospitals only did Norwoods. Some hospitals did transplant and Norwood. This one is comfort care. So what that means is that some of these hospitals chose, in concert with the families, to not do anything, okay? I'm not saying that that's right in every instance, but it's important to consider it. Some hospitals recognized they were not equipped to deal with some of the complex patients that they had, and they transferred them to hospitals that were maybe more over here on this end and could provide all of the complex things that those children needed. So what do I mean by that? One of the things that that graph tells you is the type of treatment that you receive at a hospital is a type of treatment that the hospital provides. If you go to a center where they do Norwoods and transplants, you're probably going to get offered a Norwood or a transplant. If you go to a hospital that provides comfort care that doesn't do those things, you're not going to get those types of interventions. So what's important about that is you might ask me as a surgeon, well, do you think you should do a Norwood on this baby? And I would say, yes, I think I should do a Norwood on this baby. However, when you asked physicians, what would you do if it were your child? A lot of those physicians, nurses, people that know about what happens sometimes down the road for some of these children who are very, very severely affected, some of them said, I wouldn't want my child to have that done. Okay, so I just want us to remember that, to always be compassionate and to think about the quality of our children's lives. And then finally, everything old is new again, right? Orange is the new black. You know, you can go through your mom's closet, those big, huge rings that she wore are somehow cool again. So I want to revisit ECMO because I told you in the beginning it has sort of a bad name because people don't think it's as good as VADS. I showed you that survival curve from Ryan Davies' paper. But for single ventricle patients, and we just had a question about that, there's not a great way to support them, okay? The survival when you deploy ECMO is actually not that different. And the reason why is a couple of things. In the X-Core trial, the stage 1 patients, so for your kids who are between their Norwood and their Glenn, or between their shunt and their Glenn, those patients did terribly with mechanical support other than ECMO, okay? And there's a bunch of physiologic reasons why, but the bottom line is that us as practitioners, and we at Phoenix Children's, actually, our last 5 patients we have bridged to transplant with single ventricles, we bridged them with ECMO, and they've done great, okay? So I don't want us to just throw that out because somebody publishes a paper that says it's better. Again, moving through our looking glass is taking all the best data that's out there, but individualizing it, providing precision medicine that's best for your son or your daughter or your mom or your dad, your cousin, okay? And I think this is a wonderful quote here. If you'll believe in me, I'll believe in you. Is that a bargain? And let's partner together, okay? Because sometimes we can believe as many as 6 impossible things before breakfast. But in treating kids with congenital heart disease, we gotta move beyond that. We've got to start doing the impossible and making it possible because our children, frankly, they're worth it. Thank you.
So now we have Dr. C, and again, we're going to keep moving on. If you need a break, take a break, but we're going to keep moving. We have some people with time constraints in the panels, so we're going to keep moving. Dr. Carol Malou, Dr. C, they all said they'd stick around after this so you can talk to them. And so we'll go on with the next panel after this, and then we'll have lunch, and hopefully we'll catch up.
I may as well just get started while we're getting the slides up. So thank you for inviting me. This is a terrific event, fantastic speakers, and I'm happy to be here. I'm one of the heart surgeons at Mott Children's Hospital at the University of Michigan. And today I'm going to talk to you about regenerative medicine approaches to the treatment of congenital heart disease. Thank you. So I have no disclosures to make. So before we talk about treating congenital heart disease, we have to define it. And I know many of you are familiar with congenital heart disease or specific or defect, but there are many different kinds. And I try to distill the essentials of this in one slide. So we can break it down in terms of at what scale does the problem occur? It can occur at the tissue substance level. So there could be problems with the tissue itself. It could be very weak, it could be thickened. You talk about heart muscle, it may not be functioning well, may not be contracting well. Then you can look at the structure itself, the macroscopic structure. A vessel may be deformed, it might be small, or maybe totally absent, or it might be extraneous. Okay? Then you can look at the system level, how these structures are arranged. Some structures may have an abnormal relationship to other structures. We call that the topology of how the heart is arranged. Or you can have a combination of any of these problems. So how do these malformations cause problems for the patients? Well, they can do so in a number of ways. One, these malformations can increase the workload of the heart. So over time, the overloaded heart will eventually fail. These defects can also decrease blood flow to regions of the body, and therefore those regions of the body may be starved for oxygen and nutrients. And then you might have inappropriate type of blood flow to the heart or the lungs. Specifically, you might have deoxygenated blood flowing to the body, and you might have oxygenated flowing back to the lungs where it's not needed. So how do we treat this? Well, for severe congenital heart disease, we can treat it with surgery or interventional techniques. And a lot has been discussed today about those two topics. We can reroute blood flow with surgery. We can create so-called normal structures with patches and rearrangement of the heart anatomy. We can repair or replace valves. And for patients with functional single ventricle defects, we can't cure them, we can't create new ventricles, but we can palliate them and extend their survival. But we know that these patients don't have a normal lifespan. They will eventually need replacement of their hearts. So that brings us to the limitations of the current treatment of severe forms of congenital heart disease. So structures that we create surgically or in the cath lab requires the placement of exogenous material. Okay, and these materials lack the characteristics of living tissue. These materials don't grow, they don't remodel, and they don't regenerate. When you talk about functional single ventricle defects, I just mentioned that they can certainly extend the patient's lifetime through childhood into adolescence, maybe into early adulthood, but they will not last an entire lifetime. So really better treatment is needed for those with severe forms of congenital heart disease. And that brings me to the topic of regenerative medicine. So what is regenerative medicine? So this definition was published by the National Institutes of Health back in 2006 in their white paper on regenerative medicine. It's the process of creating living functional tissues to repair or replace tissue or organ function lost due to age, disease, damage, or congenital defects. It's a very broad definition, and this so-called regenerative medicine approach can treat almost everything, it seems like. So on the cover of their white paper, they show a picture of the Greek titan Prometheus. Any of you familiar with the story of Prometheus? So Prometheus was a titan in Greek mythology, and he was very friendly to man, to humans. He gave humans the arts, civilization, and even stole fire from Zeus to give to man. Zeus was the other titan. So Zeus punished Prometheus by chaining him to the top of a mountain, and every other night an eagle came by and pecked away at his liver. Every other night. The liver is a very highly regenerative organ, so it can grow back in 48 hours, and the eagle will come back again and take bits and pieces of the liver away. So it's like a never-ending torture. because of this story, it was felt that the Greeks recognized what the liver's regenerative capacity was. So that's why they put that picture on the cover of the white paper. Well, I kind of digress, so let's get back to current times. So the FDA's definition of regenerative medicine is a little more specific. And there's essentially three components to regenerative medicine. You can have human cell and tissue a product, you can have cell therapy or stem cell therapy, and you can have tissue engineering, or a combination of any of those. Now, this was recently defined in the 21st Century Cures Act that was passed into law earlier this year. So I can't go over this entire field. It's very broad, but I will give examples of each and give you my opinions on those and how it is applicable to congenital heart disease. So is there hope or hype for regenerative medicine, for stem cell therapy, for congenital heart disease? Certainly we've heard about this concept back in 2006, even before that, so for at least a decade, but there is yet to be a regenerative medicine product that is used to treat patients. Certainly congenital heart disease, there isn't any. So in the remainder of my talk, we'll talk about this, I'll give you my opinions, and then we'll end with some of the research that I'm doing in my lab. So let's talk about stem cell therapy or cell therapy. What's the definition of a stem cell? It's a cell that can multiply and give rise to different cell types. Okay. For stem cell therapy of the heart, essentially it's injecting these cells or infusing these cells into the heart so that they improve the function of a failing heart. There are many different types of stem cells, and I'll try to give you an overview here. We can break them down into two general categories. One is a postnatal stem cell, also known in the field as adult stem cell. I think that's a kind of a misleading term because these stem cells can be isolated from perinatal tissues, neonatal tissues, as well as the adult. So I refer to them as postnatal stem cells. And these cells can be isolated from any type of tissue, essentially, the umbilical cord, the bone marrow, the thymus, the heart itself. And we don't know which stem cell is the best for stem cell therapy of the heart. We do know, though, is that in general, stem cells taken from a younger source tends to have more therapeutic potency as compared to stem cells isolated from an elderly individual. Okay. The second general category of stem cells is the so-called pluripotent stem cells. This is a cell that can expand indefinitely. This is a cell that can turn into any cell type in the body. Okay, so it's a very powerful stem cell. An example of that is the embryonic stem cell, which as scientists we can obtain from discarded embryos. But translating that into therapies is highly controversial, and there's a lot of ethical issues behind that. Okay. In the past decade, there's been the development of another type of pluripotent stem cell, and that's called the induced pluripotent stem cell. And that's something that is generated in the laboratory. So we can take a normal postnatal cell from an individual, from their skin, from their blood, from their cheek, wherever, from their hair, and then we can reprogram that cell to become a pluripotent stem cell. That is recent. There are a number of large barriers to translating these cells into the patient. First and foremost is that these cells are reprogrammed. So whenever we talk about reprogramming cells using genetic engineering techniques, we always worry that there's a risk of converting them to a cancer type cell. So there could be significant risk with putting these cells back into a patient. However, they have certainly advanced the field of cardiovascular medicine and of congenital heart disease research, because we can use these cells as models of heart tissue in the laboratory and study heart development and study the pathogenesis of congenital heart disease. Well, stem cell therapy has reached the clinic for congenital heart disease patients. This is a trial that was conducted in Japan by Dr. O and his team. This is a study that was published 2 years ago, and they looked at a group of 14 patients with hypoplastic left heart syndrome. All of these patients had surgery, stage 2 or stage 3 surgeries. Half of them had the stem cell, actually it's progenitor cell infusion into their hearts after their surgery, about a month after their surgery. Where they got the cells is from the surgery itself. They took a little piece of right atrial tissue from the operation, and then took it to the lab, isolated the cells, and expanded it, and then infused it into the coronary arteries about a month after their surgery. So in the 7 patients that underwent this stem cell infusion to the coronary arteries, if you look at them, improvement in the right ventricular function at a number of time points, the latest being 18 months. Okay, so that was very exciting. So they followed up with a larger study, and this was published this year, had 17 patients in the treatment and 17 patients in a control. And these 17 patients in the control group could get did have the option of undergoing late stem cell infusion, and actually all of them underwent late stem cell infusion 4 months after their surgery. The early study, and they only had 3 months follow-up, in general, there was an improvement in function of the right ventricle in these 17 patients. And then also in the patients that underwent infusions 4 months after surgery, they also identified a small improvement in function. However, you have to look at the details of the study to really decide whether or not this is going to be patients. So the amount of improvement in function is actually quite modest at best. Okay? There were even some patients that did not have the improvement, and one patient had worse function at the end of the study. The second thing that I want to point out to you, it's not shown here, but seen in animal studies of these stem cells, actually any type of stem cell, we do not know what these cells do. I already told you the definition of a stem cell is one that can multiply and turn into different cell types. So if we talk about stem cell therapy, we want to put a few in the heart, we want them to multiply and turn into heart cells to contribute to the heart. But if you look at animals that receive these stem cells, if you look at it in a couple months down the road, after you implant them, those cells are gone. Okay? So we don't know exactly how these cells improve function of the heart. The prevailing theory right now is that these cells actually secrete some beneficial factors. They produce beneficial factors, which then gets taken up by the surrounding heart cells of the patient. And those beneficial factors promote endogenous regeneration, promotes better function of the heart cells. Okay, promotes better survival of those heart cells. So there are, despite those unknowns, there are 3 trials out there in the world. The first one is the Apollon trial, which is a phase 3 trial, extension of the trial in Japan. It's conducted in Japan. There's another trial looking at bone marrow-derived mesenchymal stem cells from a non-related donor, and that's conducted at the University of Maryland for hypoplastic left heart syndrome patients. And there's a third of autologous umbilical cord blood cells for the treatment of HLHS. And in this third trial, they're just taking unfractionated umbilical cord blood cells. So it's It has the advantage of not requiring much manipulation of those cells outside of the body, but there could be a theoretical disadvantage that the therapeutic stem cell, if there is one in there, is really diluted down. So we'll have to see what the results of these trials show. Okay, so the next thing I want to talk about is the human cell and tissue product. Specifically, I'm going to talk about stem cell exosomes. Okay? Exosomes are produced by stem cells. They're kind of nanoscale sized packets of growth factors, of energy molecules, and other signaling factors that can stimulate the heart to regenerate. So this is potentially the mechanism by which stem cell therapy works, except we're not using the stem cells. We're harvesting these beneficial factors in the laboratory and then giving these beneficial factors to the patient. So it has not reached the clinic yet, but in animal models of heart disease using exosomes isolated from various types of stem cells, we can see that it improves heart function significantly. It has a lot of advantage over stem cell therapy. It can be isolated from stem cells from an unrelated donor. Okay, you don't have to get your own heart tissue. It can be from someone else. These exosomes can be frozen away and stored. It can be used in an off-the-shelf manner. That's very unlike stem cells because they're living. You have to isolate them, you have to expand them in the laboratory, and they have to be in culture for at least 24 hours before you put it in a patient. Not so with exosomes. It's like a drug. And because of that, it's cheaper. It's a cheaper avenue of therapy. And there's a lot more attention to stem cell exosomes nowadays by biotechnology companies for that exact reason. Okay, it's cheaper for them to manufacture this than to take stem cells from each individual patient and grow it up and then inject them back in. There are still a lot of key questions. One is was it going to work in humans? Okay. Are the beneficial effects that we see in animal models durable, long-term? Because these are just growth factors that we inject at one time point. We see benefit early on. Is that going to be something that we see years from now? Or do we need to repeat dosing? And also, which stem cell exosomes are the best? We can take a cardiac progenitor cell and isolate exosomes from it. We can take a bone marrow mesenchymal stem cell. There are many different stem cells out there, as I mentioned. Which stem cell type produces the best exosome for a particular patient? So there's a lot of key questions out there. I can tell you, I can't give you too much detail, that we, this is a project driven by Dr. Cottrell, Sanjay Cottrell at the University of Maryland, collaborating with a company called Catheterization, looking at exosomes isolated from cardiac stem cells and doing animal studies, and hopefully will be in clinical trial within the next year or so for patients with hypoplastic left heart syndrome. University of Michigan being one of those study centers. So the last type of therapy under regenerative medicine is tissue engineering. I think it's the most exciting, but it's furthest from clinical translation. It's essentially the creation of parts in the lab to implant back into a patient. It's like taking a car to a repair shop, getting the tires changed. Okay, so that's creating living tissue as patches or even entire cardiovascular structures. You can make valves, and this is from a group in Mississippi. You can even make heart tissue or even the whole heart organ. Okay. So I want to end with tissue engineering of the heart, or engineered heart tissue, because our laboratory has a lot of interest in this. So what is engineered heart tissue? Well, it's actually functional contracting heart tissue made in the laboratory that can be used to augment the function of a failing ventricle or to serve as a subpulmonary ventricle in the Fontan circulation. But there are key challenges to translating this into the patient. First is, where are you going to get all these heart cells for this engineered heart tissue? The heart is made of several billion heart cells. We want to try to make a ventricle that's going to take hundreds of millions, not billions of heart cells. Where do you get it from? Well, that's been partially solved, and as I mentioned earlier, with the advent of induced pluripotent stem cells, we can make heart cells as many as we need. But the problem is the differentiation protocols, the process of changing these induced pluripotent stem cells into heart cells has not been perfected. In the heart, there are different types of heart cells. There's the atrial heart cell and ventricular heart cell, and there's also the right and the left. Okay? We're interested in ventricular type heart cells to assist the failing heart. We don't have a protocol out there, a differentiation protocol, that will give us pure populations of ventricular type heart cells. This is another reason why we haven't seen clinical translation of induced pluripotent stem cells into patients, because if you inject these cells, they could be atrial, they could be ventricular, they could be right or left, and they can cause arrhythmias. Okay? But there's been a lot of work in the past decade, a lot of progress, and I foresee that we should be able to solve that problem within the next 5 to 10 years. The second main challenge is scale up. Okay, what do I mean by scale up? Well, the normal heart converts energy and oxygen derived from the blood into mechanical work. It pumps blood. That's its function. Okay, the heart is a muscle, and in order to do this this much amount of work, pump blood to the whole body, it has to be of a significant size and thickness. The normal heart in an adult is a centimeter thick, and a baby's maybe 5 millimeters. Okay, so quite thick. We can't make thick engineered heart tissue in the laboratory. Okay, this is a picture of engineered heart tissue under the microscope with special stains from our laboratory. We can make it in here. The heart cells are stained red. This bar here is 50 micrometers, or 0.05 millimeters. So we'd have to make that 100 times thicker in order for it to be relevant for treating patients. The reason why we can't do that is because if we try to make something thicker, the central regions get starved of oxygen and die off. Okay? It doesn't happen in our own body because there's a blood vessel system. And that blood vessel system has blood flowing through it to deliver the nutrients and oxygen. So in order to scale up engineered heart tissue, and frankly, any type of engineered tissues like the liver, the lung, whatever, brain, you have to have a blood vessel system, and it has to be perfused. So that is what my lab is focusing on. It is a very difficult problem. Scientists have been trying to solve this for the past 2 decades or so. First of all, it's a multi-scalar problem. Blood vessels come in many different sizes, right? You can see blood vessels with your own eyes, so macroscopic scale, and there's also a microscopic scale of blood vessels, and that's the capillary network. This capillary network is very important because that's where the exchange of oxygen and energy occurs with the heart cells. Okay, and finally, as I mentioned, you need flow through this vascular network to keep the engineered tissue alive and to be able to make it thicker. So we're approaching this by using some special perivascular stem cells to drive blood vessel formation in the laboratory. We've studied them. We've studied how different culture geometries can stimulate the behavior of these cells to form blood vessels, for instance, in less than 24 hours. You can see these nice sprouting networks forming. And then we can actually form linear cylindrical structures that look like a vessel, and then given a week, show a very dense and complex sprouting network. Okay. But as I mentioned, the second thing to this is perfusion. You have to have something flowing through these vessels to support the engineered heart tissue. And so these networks that we're creating in the lab, if we flow blood through them, you can see that they're patent, they're hollow. We can flow blood through them, and they actually flow down the branches. And we can also subject them to pulsatile flow to condition these vessels to become stronger so that when you implant them, they won't rush. So based on this work with these perivascular stem cells, we are formulating special bioinks. People have talked about 3D printing. Well, we're going to take this a step further and utilize 3D bioprinting, where we actually print living tissues. And the inks that we're developing will be used to create blood vessel networks, as well as put the living heart cells around these blood vessel networks, so we can 3D print living heart tissue. So, jammed up here. Computer's wrong. Anyways, so in summary, the current treatment of severe congenital heart disease is not a cure, unfortunately. Regenerative medicine strategies have the potential of improving the care of these patients. Certainly, stem cell therapy is in clinical translation, closer to clinical translation, but I think it can be improved upon. I think stem cell exosomes is the next thing on the horizon, and we're going to be excited to start this trial. And tissue engineering holds the greatest theoretical potential for our patients. However, it's the furthest from clinical translation because of the lack of these blood vessel networks. So thank you again for inviting me, and happy to answer any questions.
So I'm going to invite the next speaker up. Why don't you guys get up and stretch while we're doing that a little bit? Everyone stand up and stretch. And we're going to go ahead so we can get lunch on time, and then we'll start the afternoon panels and try to keep that going on time, a good time schedule. Yes. Not yet. Lunch is at 1 after this panel.
I know. Big head being on there. Okay, I'm on the wrong. This one stuck.